I'm Dr. Lisa Straight. I'm an associate editor at Gastrointestinal Endoscopy, and it's my pleasure to be here today with Dr. Michael Bartel. He's from the Mayo Clinic Jacksonville, and we're going to discuss a paper entitled Endoscopic Mucosal Resection Learning Curve for Large Non-Polypoid Colorectal Neoplasia. So welcome. Thank you for this very interesting work. In reading it, I was somewhat surprised by the fairly long length of time it took for even experts to learn this technique. I wondered if you could comment briefly on your findings and what the implications of them are.
Absolutely. Thank you very much for the kind invitation. And indeed, we've been also surprised. So our main outcome, or one of the main outcome measures to measure really expertise in the EMR outcome was the residual neoplasia at follow-up. And we found that the residual neoplasia of approximately 20% plateaued after 100 EMRs. Prior to that, it was higher. And this was, we suspected that several aspects contributed to the fact. One of them, in opposed to many other publications, for example, like in the ESD field, we have 3 experts indeed who did the EMRs, but we didn't have any teaching session. These were self-teaching session, which usually obviously requires more time to receive expertise. And also, over time, we have to be aware of that it took time for everyone, every endoscopist to find his right way to use the correct snares, and everyone actually used other snares and other way of equipment to reach his personal optimal setting, which felt comfortable. And in this kind of non-teaching session, it took roughly 100 EMRs to reach that level. And actually, more interestingly, we found that after roughly 100 EMRs, once this plateau of residual neoplasia was reached, actually the residual neoplasia increased by around 5%. And we looked then for the reasons, and here we found that after reaching really expertise, the endoscopist was willing to do EMRs on larger polyps, EMRs which previously failed. And this might be also a reason why we had this mild increase of residual neoplasia afterwards.
Right. I noticed there was sort of an ebb and flow in a curve, almost as if they learned, got comfortable with their new expertise, and then took on harder things. It seemed like there was a jump and then a fall in the residual neoplasia for a while until it evened out.
Yes, correct. And then we had once they reached even, and also it was not more statistically significant, once they even got better after 100 EMRs, approximately at 200 EMRs, we had again a decrease of residual neoplasia.
And what there are there's a high demand for EMR for large colon lesions. You mentioned training sessions. What do you think the implications are in practice for people to learn? It's obviously doing 100 is a large number, and how we might reduce that learning curve or at least facilitate optimal EMR in clinical practice.
So that's really important. In particular, ASG is very successful at doing this teaching sessions in Chicago, and our implication here is that, and this is what we extrapolate from the data on ESD, because ESD was shown to have a higher, faster learning curve once ESD is performed under supervision. And we suspect that, also it was never measured, but our hypothesis is that the EMR learning might be expedited once it is learned under supervision of an expert in that field.
And what about technique? You mentioned that the endoscopists changed their technique over time. Did there become sort of a standardized technique? Were they, in the end, all 3 endoscopists using similar methods in order to achieve the minimal residual neoplasia?
So it's surprisingly not the case. So we had 3 expert endoscopists, and everyone had, for his personal discretion, for wherever the polyp was found, whether it's more the rectum or the cecum, the size, is it is it truly flat polyp? We had different types of injections. Some endoscopists preferred using so gonag, some preferred using without gonag, and then also the different types of snares. Every endoscopist had, over time, reached his personal kind of preferred snare subset, which are usually 2 to 3 snares for each endoscopist, and that's where the snares would they used for EMRs. But we can't really tell that a certain subset of snares was the overall optimal one.
That may be, I guess, difficult in standardizing in practice, but
it is, yeah.
In some ways allows endoscopists some leeway in terms of what equipment they have already.
Exactly. So this is, and there's a lot of equipment out, and it just takes time to get his, to learn his own preferred equipment.
So thank you very much, Dr. Bartel, for being here today to discuss this interesting article. I really look forward to seeing it in press in gastrointestinal endoscopy.
And thank you also very much for this very kind interview, and we also look forward to see it soon in press. Thank you.